Welcome to AFMC TV. I'm Robin Linder.
The goal of that is to maximize people's quality of life, right?
You want to make sure that your housing is affordable in your community.
We have to think about vaccines in a way that we haven't thought about them before.
I had a lot of religious adults who were very creative.
Down on the floor and play with their kids.
AFMC TV, thanks for watching and have a great day. Welcome to AFMC TV. I'm Robin Ledbetter. Thank you for joining us. Today I have with me Dr. Sam MaKhoul. He's a hematologist, oncologist, and medical director of the Clinical Research Department at Carti Cancer Center and a board trustee member of the American Cancer Society. Dr. MaKhoul, thank you so much for being here.
Oh, thank you for inviting me. I'm very happy to be with you today.
So recent studies from the American Cancer Society and the NIH showed troubling trends in cancer diagnoses among people under age 50. Could you briefly tell us what these studies found overall and what early onset cancer means?
This is really very troubling phenomenon that we have been observing now over the last 5 to 6 years since we started comparing notes and statistics and what have you. And the idea is that early onset cancer is a cancer that starts at an age that is not expected to have cancer, which is in the young population, because cancer is well known as disease of the older population. And here we define it, any cancer that happens between age 15 and 50. Because we have childhood cancers that happen due to genetic, mutations and abnormalities, and they are special. And the number of childhood cancers is small. We're talking about probably 20,000 cases in the United States, while at this point, total number of cases of cancer in the United States has reached 2.1 million cases. So, and the portion that is related to this population between 15 and 50 is about 15% globally. But we notice that in 13 out of 34 cancers that we follow closely because they are the most common ones, there is an increase in incidence in this population between 15 and 50. And that is a troubling situation that calls for, first of all, trying to understand why and see if we can bring about certain measures to mitigate that increase in the incidence of cancer.
How do these national trends compare with what we're seeing in Arkansas in terms of cancer incidence and mortality?
Honestly, to tell you the truth, when I looked at, I compared, and for my, to understand exactly the trends in Arkansas, and I looked at certain cancers, there is definite decrease of mortality globally from cancer in Arkansas. That mirrors what happens now in the United States as a whole. And when you look, for example, at specific cancers such as breast cancer, lung cancer, colorectal cancer, we are enjoying, I should say, the same decrease of mortality that the rest of the nation is enjoying. Although I can tell you, we start from higher levels of mortality. Let me take lung cancer, for example. Lung cancer, we have, and we are still ranking at the highest level of incidence of lung cancer. And we are not the highest in mortality, but our mortality is still not good. So when you start high, you can improve. You see what I mean? You are very high and you do something, you can improve. The issue is that we definitely still need to do a lot regarding lung cancer. Now, I added up the mortality, the estimated mortality by the American Cancer Society for Arkansas from lung cancer. And in 2026, we are expecting to have, I think, 1,680 people to die of lung cancer. It's practically the same number from breast cancer, prostate cancer, colorectal cancer, and pancreatic cancer combined.
One American Cancer Society analysis noted that colorectal cancer has become the leading cause of cancer and deaths in adults under 50, even as overall cancer deaths fall. Why is that such a concern?
It is really a very intriguing situation, and I will give you the percentages of increase, actually. It's about 1.7% a year. Although I told you that the majority of the patients are diagnosed beyond age 50. But when you add 1.7% to 1.7% in this age group we're talking about, the younger than 50, every year you are adding 1.7%. 10 years, you have 17% increase, right? And so that's exactly what happened. And to understand this trend, many people smarter than me are working on it. And what we have realized that there are certain factors, and we talked about this last year. The epidemic of obesity, it seems like, is one of the major factors impacting the high incidence of colorectal cancer in this population. The issue is that there are other factors too. Our sedentary lifestyle, it seems, and also our diet. So these three factors, you don't move around, you eat poorly, you gain weight, and all of them compounded lead to higher probability that you develop cancer.
And has anything about how we screen or diagnosed cancers changed in ways that might partially explain a lot of these trends as well?
Thank you for this question, because we debate this question all the time at scientific meetings. And there are people who are opposed to the idea of widespread screening, because they said we detect cancers that are not necessarily going to hurt the host or the patient, but these are things that happen, and probably people, if we did not know about it, would die with them, not of them. So that is the concept of overdiagnosis. And some people attribute some of the rise to the fact that we are screening more, finding out about things a little bit more. And some of those cancers are wannabe cancer. They would never develop really the cancer disease. They're only cancer phenomenon because we found them in certain tissue, the colon, for example, the prostate or the breast or something. So this overdiagnosis concept has been floated around for a long period of time. And I think the idea of it is, let me give you an example how overdiagnosis happened in certain situations. Like prostate cancer is one of the cancers that that is extremely common in males. And if you look at autopsy series, meaning studies that were done on patients, males who died of something else, stroke, heart attack, car crash, stuff like that. And they did autopsies on those patients. And they found out that by age 80, the risk to have some form of prostate cancer in the prostate is close to 70%.
And what are the key symptoms or warning signs that younger adults should know about that might prompt earlier evaluation?
I thank you for this question. This is really very important. First of all, I want to highlight the fact that for colorectal cancer, considering the increase of incidence of colorectal cancer in this population, the decision was made to drop the age of screening to 45 rather than 50 a few years ago. And that would allow us definitely to detect cases that are early stages, but also that would allow us to remove the polyps that are considered the precursors, the seed for the development of a future cancer. So that is very good. But usually screening, I want to highlight that fact for all cancers. Screening is for people who have no cancer and no symptoms of cancer. So when I talk to some patients and they tell me, oh, they come to me for different reasons other than cancer. Let's say you have anemia and tell them, oh, you're eligible for screening. They say, I don't have any symptoms. I said, perfect. This is the time to do it because you don't have any symptoms. We can detect the cancer if there is one early and remove it. So screening is for healthy people who meet the criteria. I have to highlight that. Now, symptoms for colorectal cancer, I have seen it very commonly. Now, young women, for example, can get anemic because they have heavy periods. And once in a while, they see drop of blood in their stools. They might blow it off. They say, oh, that's probably from my periods. Don't ever ignore any blood coming with the stools. That is, kind of common and basic rule. In addition to that, some patients would start having, for colorectal cancer in particular, I'm going to say some alternation of constipation and diarrhea. crampy abdominal pain. Those are symptoms that should call for further investigation. We should not attribute that, oh, my periods are very, heavy, and then I have more symptoms around the periods, and that should not be the situation. And any blood in the stool should be fully investigated. It's not only hemorrhoids. Don't rest on that easy diagnosis, because this is not true.
And there is positive gain. I mean, there has been significant decrease in mortality. Is that worldwide?
That's, in most of the developed countries, fortunately, there is decrease in mortality, a significant decline in mortality from cancer. And in the United States, we have about 34% decrease as compared to the 1990 statistics. And here, when we talk about 34%, we're talking about age-adjusted decrease, meaning you have an age group, for example, that if you had the breast cancer and you are between 50 and 60 or 60 and 70 and so on, the mortality rate would be per 100,000 population, that many. That's what we talk about. So the growth of the population might also be reflected in higher total number of people dying of cancer. But in reality, the incidence would go up. And when you report that to the age group that you belong to, there is definite decrease in mortality by 34%. And there are about 5.4 million lives that were spared from dying from cancer over the last 30 years. And that is a dramatic improvement. Really, we need to be to celebrate it and be thankful for the advancement of research.
Well, Dr. MaKhoul, thank you. Thank you for sharing so much important information and talking about Arkansas and globally how these rates affect the population. Before we go, tell us, what can local healthcare providers, policymakers, even everyday citizens do to help reverse the trends and support younger people at risk?
I think one of the most important achievements at this point is the approval of drugs that would help curb, the epidemic of obesity. In my opinion, at this point, we know that bariatric surgery has become, starting on January 1st of this year, an approved procedure for a chronic disease that we call it obesity. And I always talk to my patients, I say, sometimes the shame and the blame strategy that even medical professionals have used for decades about obesity, instead of naming the thing as it is, which is a disease. People who get that increase of the fat mass in their body, they're not making this choice because whatever, you know what I mean? And once we have understood that obesity is a disease, it became important for us to try to find solutions. And bariatric surgery was one of the solutions. And I think it still has its place in treating obesity. Now, once we have defined obesity as a chronic illness, and this has started with another organization that I'm a member of also, and member of the board of trustees of that organization, which is the Arkansas Medical Society. About 2 years ago, we started an initiative to declare obesity as a chronic disease. And by this declaration and finally adoption of measures and treatments that have been approved scientifically and proven scientifically that they work, we were able to, at this point, start offering this option to our patients. I had several patients who had a BMI, which is not body mass index, by the way. It's not the perfect way to define obesity, but this is the standard that everybody can understand, who have like BMI 45, 50, and they can't move, and they needed that surgery. And yet 2 or 3 years ago, this would not have been approved. Now it is. I think the next chapter of this is for patients who don't want or cannot have the bariatric surgery for different reasons. They cannot undergo the surgery, for example. We need to make sure that the medical treatment, less invasive treatment, basically the GLP-1 and GIP, also receptor analogs, these are drugs that help decrease weight significantly, are approved for those patients.
Well, Dr. MaKhoul, thank you. Thank you for sharing this important information and for being here today to share about the health and the future of Arkansas and globally with these important research and studies. Thank you.
You're welcome. Thank you.
And that's it for this episode of AFMC TV. Thanks for watching and have a great day.